Okay. All right. Well, look, I just want to re-emphasize there what Anne was saying about, developing and sharing practice. Anne taught me huge amounts. When I was and Gareth before, and the other guy when I was training in my pre-hospital work. But more importantly, the work that they did, especially in brain injury, around the use of Octaplex and Beriplex for warfarin patients on warfarin, has filtered out throughout the whole of the UK and if not beyond in terms of optimizing practice. So that, I just want to emphasize that these things that you see here, although they sound really simple now, at the time they were groundbreaking and revolutionary and just taken for granted now, but they do make a big difference. So I'm going to talk to you about two topics: hyperacute TBI and pre-hospital care, which I think is far too much in 15 minutes. So I'm going to focus on what I perceive as to be the important components of those two elements. You can probably hear it's raining here quite a lot as well, so sorry if it's being drowned out of it. And as I said at the start, I'm also a co-founder and medical director of Good Sound, which does get a mention towards the end, so I don't want to I want to make you clear of that. It's not profit thing, but anyway, I still want to make that clear. So I often start my talks, if you've seen me talk before, I apologize, saying that if you're not dead, you shouldn't die. And I don't mean that categorically, but what I do mean is that when your primary brain injury is when your head hits the windscreen, secondary brain injury is everything that happens after that. And it's our job as clinicians and scientists to minimize the involvement of that brain injury, whether it be hypoxia, hypotension, or any other causes of secondary brain injury. And that's what this talk is about. It's really focusing on minimizing secondary brain injury. And why do we do that? Well, because brain injury is actually a really bad thing. Is breaking your arms and legs is bad too, but brain injury has a very long-term ongoing effect. And I see this all the time in my patients who are often not quite the same after they've had a brain injury. And there's usually a period where they're very, very vulnerable in the first few months, they become a bit aggressive, partners leave them, they lose their job, they lose their house, and actually the whole world for them falls apart. And this is a time when actually they are very vulnerable and they need to be looked after. But if we can minimize neuronal loss and keep that person the same person they were, then hopefully you can reduce that. And put that in context, if you look at the homeless population in Leeds, about half of the population, their homeless population, report having had a significant brain injury, admitted to hospital for more than 2 days. And if you look at the prison population, 65% in some studies. So it's really a problem of the vulnerable, and it really is a problem of society. So here we go, running through secondary brain injuries quite quickly. You probably heard Gareth Davies and others talk about impact brain apnea over the last few years. This is a phenomenon that I think was very much underappreciated. When your head hits the windscreen, one of the things that we suspect happens is people stop breathing. This is a phenomenon that is well known in animals. This is a study from 1896, and this is a dog breathing away quite happily on that top line there. And then Kramer put a metal plate on the side of the dog's head, shot the metal plate, dog gets brain injury, stops breathing, he resuscitates dog with dog bag valve mask, dog starts breathing again, dog lives happily ever after. If you don't resuscitate the dog during that period of apnea, the dog will die. You might also like to notice that there's a catecholamine rise during that and a blood pressure surge. We are not allowed to do these experiments in humans, but we are pretty sure a similar phenomenon occurs, because it doesn't matter what animal you take, whether it be rats, cats, dogs, whatever you take, if you hit them over the head, they stop breathing. And it doesn't matter how you hit them. The harder you hit them, the longer they stop breathing for. This is a paper that John Hines, Gareth and others published a few years ago, really around the experiences of the TT kind of races where people come off their motorbike, and then this is a phenomenon that we see. This is also quite relevant for hypotension. We see a number of brain injuries, probably about 15%, that present as code red patients, but actually they're just isolated TBIs. And ATS will always teach you that you can't be hypotensive from a brain injury, but you can. What ATS means is you can't bleed enough inside your cranium, but you can certainly have the vasoactive effects of that. And this is unfortunately how we commonly see these patients on ITU. They have their hypoxic brain injury and they die, and their cause of death, as Gareth Greer's always pointed out, their cause of death is put down as a traumatic brain injury, but they're not. They're dying of hypoxic brain injury because they've lost their ability to breathe. And these patients might well have done okay if someone had looked after their airway and ventilated them early on. And that's why we set up Good Sound right at the start, probably about 7 or 8 years ago now. It was a spin out really from the work we were seeing of patients who are apneic. And what we wanted to do was alert off-duty doctors, nurses, paramedics to trauma nearby to go and hold someone's airway open whilst the ambulance was en route. And all that best stuff that Gareth Davies was talking about earlier about the time domain is really important when it comes to neurons. obviously. This has a much bigger role in cardiac arrest, and it's deployed now across the UK, large parts of Australia, New Zealand, and other places, where it saves many lives by providing early CPR and early AED use. So a bit about hypoxia there. Just sticking with hypoxia for a few more minutes. It used to be felt that in TBI and traumatic brain injury, pre-hospital intubation was a bad thing. And that was mostly based out of American studies where they were getting paramedics to anesthetize people who, and basically they weren't trained in anesthesia. And they were comparing them to anesthetists in hospital and found out that patients who were anesthetized pre-hospitally did worse because they had a very high esophageal intubation rate. But in a well-governed system like London HEMS, the actual procedure is a safe procedure. That's been shown time and time again. And moreover, in studies, mostly in Australia, where they've got very well-trained paramedics, it's been shown that it actually improves severe TBI survival at 6 months. So the shift over the last 20, 30 years has gone from being pre-hospital intubation being a bad thing to being actually a very good thing when delivered in a advanced governed way. The question now is, how should you be doing it? And as Gareth said, that we've moved away from etomidate and sucks to ketamine and rock as our induction agents, which we can talk about if we have questions later on. But where should we doing direct laryngoscopy? Should we be doing video laryngoscopy? These are the new questions. And one of the things that is quite significant is the access to the ability to do laryngoscopy and provide a definitive airway. That's fine in London, where you've got HEMS, which will be there within 15, 20 minutes to most places. But actually, in the rest of the country, at 2 o'clock on a Tuesday morning, that is not something that's going to come along, despite the nice guidelines saying that everyone should be intubated within 45 minutes. So that's another thing we can possibly mention a bit later on. So we talk about hypoxia. Next, secondary brain injury, blood pressure. It's well known that if you have hypotension, your chances of mortality increase with TBI. That's been shown time and time and time again. And I do have a little bit of an issue with this, because in all these studies, TBI has been put into a bucket, and all TBI is treated the same. If you do that with cancer, so we take a bucket of cancer and we give them these medications, bleomycin, etoposide, cisplatin, you will find you increase mortality. But in one group, the testicular group, you may well cure them. And it's the same when it comes to TBI. TBI has lots of different pathologies, and I know it's so tempting to put them all in one bucket, but they are not the same. And to emphasize that, and I know that everyone watching this probably goes, well, we know all this, but please just hear me out. That one on the top there says extradural hematoma. Even today I asked a whole load of very qualified registrars what kind of brain injury an extradural hematoma was. Was it a primary brain injury, secondary brain injury? There was debate. It is not a brain injury. It is a blood clot outside the brain. If I take that out, the patient goes home. And a few days later, they come back and they're normal. Similarly with subdural hematomas. Chronic subdurals in old patients, they don't have a brain injury. They go home, they're fine. So extradurals and subdurals are not brain injury, but I guarantee you they are in your TBI protocol bucket of brain injuries, but they aren't actually brain injuries. The ones we operate on, and they do well because they've got brain injury. Contusions, things that evolve, and subarachnoid hemorrhage that can also evolve. That is a brain injury, or parenchymal brain injury, when you actually see contusions and hematomas like that. Diffuse axonal injury is a brain injury. It's the shearing of the grey and the white matter. And I should say here that the difference between all these blunt injuries is that extradurals are usually caused because something hits you, like a hammer or a bat, whereas all the others are shearing injuries from sudden deceleration. Your brain or your head hits the floor, and either your brain carries on moving and strips it away from the dura, causing a subdural, or the grey and the white matter shear against each other, causing diffuse axonal injury. I'm not going to talk about penetrating injury. I haven't got nowhere near enough time for that in 15 minutes. But they're all different types of brain injury. And whilst hypertensing, for example, diffuse axonal injury might be the right thing to do to maintain cerebral perfusion pressure, we don't know if that's true for extradural hematomas. It might be that we make it worse. Intuitively, you might think so. So we talked a bit about hypoxia, blood pressure, talk a bit about end-tidal CO2 now. Traditionally, go back 20 years, the idea was to hyperventilate people to lower their intracranial pressure, and you saw people's come down when you do that, which is true, you do. But unfortunately, the work that Jonathan Coles showed that also reduces cerebral perfusion using PET scanning. So now we pretty much say normal end-tidal CO2. Cooling patients is another thing that we can try and do to minimize secondary brain injury. You've already heard a little about Trexagas, we'll come to that in a minute, but cooling patients in the ITU environment has been shown to be a bad thing by Eurotherm, and the POLAR study, which was conducted in the pre-hospital arena, demonstrated no evidence of benefit. But the POLAR study where they were cooling people was by infusing 4 degrees C saline. And we know from post-cardiac arrest, that's a bad thing. Infusing people with liters and liters of cold saline tends to be a bad thing. So it's not about the cooling, it's about how you've done it. So again, that didn't show any evidence, but it doesn't mean that cooling doesn't work in the early environment. It just means we haven't done a study yet that shows the correct way of doing it. Bleeding. We've heard a little bit about bleeding already, and I'm not going to try and go over that. But as I said, Anne was very instrumental in fundamentally changing how we manage warfarin patients in the pre-hospital arena by introducing prothrombin complex, oxypex, and variplex in that early phase. And I think that makes a big difference to clot involvement. Go back 20 years, you had to have an argument with a hematologist in ED before you got anything. We now have a similar sort of thing though with NOACs and DOACs. They're much more difficult to reverse. Nexate alpha is available, but it's much harder to come across. And I don't really know if people are using this in the pre-hospital environment yet. But these are the patients that I have the real problems with. The ones that have a head injury, who have becoming a bit confused and you think, oh, a bit of a confusion there. Okay, well, there's nothing to do. So you don't do anything, but then 3 hours later, that's what their brain scan looks like. And that person who could potentially have gone home is now going to be lucky if they survive. And there is a window of opportunity there where we could have intervened. And what should we be doing? Well, Patch said we shouldn't probably give platelets. I won't go through this, we've already got time. But maybe one of the things we should be doing is, well, not should be, we should be now giving tranexamic acid. And that's from the CRASH 3 study, which showed in a large number of patients, 12,000 patients, that giving tranexamic acid reduced head injury related mortality in the mild to moderate severity group. There's lots of controversy about this study. It's a really big study. It's a really good study. Hats off to them pulling it off. But there's a couple of things. They weren't planning to look at the mild and moderate group together, and it talks about head injury related mortality. Many of my patients don't die of their brain injury. They die of their chest infection afterwards. And you could argue that some drugs like arsenic are really good at reducing brain injury related mortality because you give it and they don't die of a brain injury. They might be dying of something else. There are other studies out there that have not found the same thing, but I personally think that certainly in the elderly population, especially the ones on aspirin or alcoholics who have got contusion evolvement, that tranexamic acid probably reduces that contusion evolving further. So, and the earlier you give it, the better effect it's going to have. I've got 3 minutes left in my 15 minutes, so very quickly talk about intracranial pressure. We're all very familiar with intracranial pressure from the Monro-Kelly doctrine, but I just want to point out to you that it's not quite as simple as that. The Monro-Kelly doctrine was put forward at a time when we didn't even know about CSF. And these guys, over the last couple of years, found out about CSF. And then they basically said the skull's a closed box. And if you put something in, you push something else out. And that's true. However, you've got to bear in mind that you're also pumping a litre of blood into your head every minute, and a litre of blood has to come out every minute. That's compared to the 0.03 mils of CSF you're producing every minute. And your outflow is very much dependent on your jugular veins. Not so in other animals, but in humans, it's very much dependent on that. So anything that puts back pressure or obstructs those is a bad thing. So if you've got a collar around someone's neck, obviously that's going to jack up their pressure. It's like having it's basically like obstructing the outflow of a plug. If you're hypoxic from a chest injury, or if you're having to possibly pressure ventilate someone, you're increasing their intrathoracic pressures, which again will reduce venous flow. And if they're hypoxic, you'll also increase their cerebral blood flow. So they've got a double whammy. They've got the taps turned on higher, and they've got an obstruction to venous outflow. And similarly, when people are doing operations on someone's abdomen, and I'm trying to do a craniotomy, you find that when they're closing the abdomen, the brain starts to herniate out. And that's because the whole lot's connected through the SVC and IVC. So intracranial pressure is not just a pressure that's going on inside your head. It reflects what else is going on in your venous system. I just want to emphasize that a little bit. And ways you can lower intracranial pressure, head up, properly paralyzing, sedating patients, using hypertonic saline or mannitol. These are all important things to be doing whilst getting definitive treatment, which may well be surgery or an EVD or something similar to lower that intracranial pressure. I've got 1 minute left, so I'm going to talk about future of on-scene diagnosis very quickly. There's two main things that I think are really exciting in the future, one of which is biomarkers and the other is imaging. Biomarkers are released from astrocytes when they're injured, and there's lots of great studies now that show that S100, for example, is very useful in people with GCS14 as to predicting correctly whether or not they should have a CT scan. But there's two, UCLH 1 and GFAP, which will probably be coming out much more in an ED environment over the next couple of years, which I think will hopefully be adopted into guidelines and hopefully reduce our CT scanning need and therefore reduce that radiation dosage. Imaging in the pre-hospital environment has been done with a few devices. This is an infrascanner which uses an infrared light. The problem with it is it gets a high false positive rate because it can pick up subgaleal hematomas as well. And then there's mobile CT scanning, which is used for stroke in some parts of the world, but not really used for trauma yet. And the very final thing I'm going to say in the last 30 seconds is some of the stuff we mentioned with Good Sam, which is about our ability to diagnose remotely through people's cameras. So this is where we can open up people's cameras when they make their 999 call, see what the injury looks like, see what the patient looks like, see what the scene looks like, and then work out what we're going to triage to them, whether that be the air ambulance, an ambulance, or the correct resource. And there's loads of examples of this now. You know, when someone says, my husband's fallen down the stairs, the fact you can see is older, you might be able to see his conscious level, you might be able to see whether he localizes, those sorts of things gives you a much better idea. And elderly falls is a huge volume of work now, as everyone watching this will know. And there's lots of clever stuff you can do with that video. You can forward it on to colleagues, for example, the air ambulance and other things, and make better decisions based around that. It also means we can provide treatment before we get there. And that's what I find is really exciting. You know, right at the start, we talked about impact brain apnea. If we can see someone is not breathing or that their face is in the mud, when, you know, in that 2 minutes after the phone call, we can then work through the person who's made that call. We can work through their hands to put the patient in the recovery position, to open their airway, all the things that would normally take us 10, 15 minutes at best to get there to do. And that's probably going to have a bigger impact in terms of saving neurons than, you know, when we arrive giving a drug that may or may not help at that point. So it's a lot of pre-hospital care is logistic stuff and using technology to our advantage to provide that care even earlier. So I think it was about 15 minutes and 30 seconds, but I hope that was okay. Cool. Thanks, Ash.
No worries. That was awesome, Mark. I learned a lot. I had a quick question, if that's all right, Mark. I think a common scenario a lot of people you know, kind of have go to as pre-hospital care providers in whatever form are the kind of, you know, alcohol intoxicated patient and low GCS. You know, is this a head injury that they've had a low energy standing height fall and they're intoxicated and got a true head injury, or is it more an alcohol thing? Have you got any tips on how to help differentiate between that group, or where do you keep your threshold? Or do you think something like on-scene imaging and the use of biomarkers maybe pre-hospitally can help kind of rationalize what you do with this group?
So I still find that the most difficult thing I do in medicine in terms of working out what's going on. You know, are they drunk? Are they on drugs? Are they still agitated because they were in a fight before? Is it just normal for their personality? All those sorts of things I find very difficult to distinguish. And I guess what you do all the time is you just start to put those elements together, you know, and get experience putting the mechanism together and trying to rationalize all those things. But at the end of the day, we've got fairly clear guidance around when we shouldn't be intubating patients. And you know, this is such a massive topic. Done in a well-governed environment, it is a safe procedure. Yeah. And not doing it and then having someone who's vomited and aspirated on you and has a head injury is a disaster. So yeah, I think I don't really have any advice other than what I always try and tell people to do, which is try and work out in your mind what is going on in that person's head. So if they're, you know, 80 years old and they've fallen from standing, they've had a gradual deterioration, you're thinking probably so extra, you know, so some form of subdural or something similar that's evolving, but they're going to need they're heading towards intubation. But you always try and work out what the mechanism and the patient themselves, their demographic, sort of lead into what kind of injury they're going to be evolving.